Okay, so what we're going to talk about today is chronic care management and the care management services that go along with that. Of course, the care management services are what you're going to be billing for. And we'll talk about how you document those, the time that goes along with those, what activities and things will be part of that. Just as a reminder, and I think one of my colleagues placed this into the chat function, if you have questions as we're going through the presentation, enter them into the chat. You want to indicate or you want to choose from the drop-down box all panelists, and that way it will go to my colleagues who are on the presentation today. And then we'll be able to answer your questions as we go through. Just as a reminder, you do want to be on the call for the entire length of the call in order, or the webinar actually, in order to get credit for that. And then after the presentation's over, we'll receive that report from the vendor. We'll be able to mark you as complete. So just another kind of housekeeping thing, on page 1 of your handout, we have a list of all of the acronyms that we'll be using throughout today's presentation. Medicare, as a governmental contractor, obviously has lots and lots of acronyms. So we want to give you a list of those so you can see what we're talking about. So our objective for this presentation today is we want you to have the information you need so that you can bill Medicare for the monthly care management services and you can receive reimbursement. So this is going to include documentation, ways that you can meet the requirements that we're going to be talking about. We want you to have this information so that you can receive payment from Medicare for these services. We are aware that most of your offices are providing these services to your patients. And if you structure it correctly within your office, within your processes and your workflows, and you get that documentation in there, then you can bill Medicare for the service. So it's not like really you're providing a bunch of additional services for the patient. It really is just structuring that so that you can receive payment for what you're already doing. So what we're going to be talking about today is just a brief overview of chronic care management, or CCM itself. One of the things we want to remind you of is that use of the terminology chronic care management really is an umbrella terminology, and it includes chronic care management. It also includes complex chronic care management, and it includes principal care management. And so we'll be talking about all of those things as we go through. We have a ton of additional resources for you. These include YouTube videos on our YouTube channel. We are getting ready, in fact, probably within the next 2 or 3 weeks, to record a conversation with our contractor medical director with some different questions and things that we have received from providers, and really how to begin a chronic care management program within your offices. We will publish, when we publish that to YouTube, we will publish that within our Wednesday e-news to let you know that that's available. We also have within our Learning Center encore presentations from previous webinars that we have done. That includes all of the overview information about CCM. It includes the initiating visit, a lot of different information in there. So we're providing you information today on how the care plan is really going to direct your monthly care management service. We'll discuss who can provide the service and what that means for billing. And then we'll discuss the general requirements of the care plan service itself. So the information we have up on your slide now deals with the patient eligibility for chronic care management services. And you can see there it's divided into two different sections, the chronic care management, complex chronic care management, and then principal care management. When you're providing your monthly service, one of the things that you will want to do is to verify that your patient still meets these guidelines. Most of the time, your patient is still going to meet the guidelines. As you can see there, for chronic care management and complex chronic care management, patient has 2 or more chronic conditions. The conditions are expected to last at least 12 months or until the death of the patient, and it places the patient at significant risk. So that second bullet point, expected to last at least 12 months or until the death of your patient, that's where it probably means that once your patient is involved in chronic care management, they can stay involved. But you just want to check on a periodic basis to make sure that your patient still meets those requirements. And then for principal care management, it is a single high-risk condition expected to last at least 3 months or until the death of the patient. And it places the patient at risk of hospitalization or other care that the patient may need. In addition to that, for principal care management, there are needed medication updates, and the patient could have an unusually complex situation based on their comorbidities. The patient can receive only one CCM or complex CCM in a single month. What that means is that only one practitioner can actually submit. When you're talking to your patient about chronic care management, that's one of the questions that you want to ask them is whether or not anyone else is billing for this. If so, then you can't bill for it. If not, then of course you can. In addition to that, though, the patient may be receiving principal care management from other practitioners. We had a pre-submitted question by Kathleen that wanted to know if Medicare had a list of the chronic conditions. And CMS has provided an example list, but that list is not all inclusive. This is in the CMS Medicare Learning Networks booklet on chronic care management services, and we have that resource listed for you in your handout itself. So due to the care of your patient, the instructions that you have provided to your patient, those are the things that we're going to be looking at within the documentation, should Medicare request it, of your chronic care management service itself. So here are the providers who are eligible in order to bill for this service. And you can see physicians, non-physician practitioners, rural health clinics, federally qualified health clinics, and hospital outpatient departments. Now, these are going to be the billing providers. Most of the time, Medicare would expect that the services are actually going to be provided, though, by your clinical staff. Now, your clinical staff, when they're providing these services, are going to be working under the Incident 2 requirements. And there's information out on our website, in the CMS website, about all of those different requirements. There are requirements for an employment relationship between the billing practitioner and that clinical staff. There's requirements about supervision. And for CCM services, it is general supervision, not direct supervision. Direct supervision would mean the practitioner has to be in the office when this is happening. General supervision simply means that your practitioner is overseeing what your clinical staff are doing. The clinical staff, the services that they are providing to your patients obviously have to meet any state or local requirements that there may be in place. And then your facility has to consider them clinical staff. Examples of this could be your RNs, could be your licensed practical nurses, etc. Mary, I see that you have your hand up.
Yes, Ellen, I am going to seek some clarification from Justine, who sent us a message in the chat. She wants to clarify or verify CCM can only be billed one time per month by one provider, but PCM may be billed monthly by more than one provider.
And that is correct. One of the things that Medicare will watch for in the billing of chronic care management, number one, is that only one provider is billing only once for chronic care management or complex chronic care management. So for an example, Dr. Jones is the one providing this. He's going to submit the procedure codes we're going to talk about here shortly. You can also have another physician or practitioner who is providing principal care management, meaning that they're dealing with one particular problem or condition that that patient has. And so what Medicare will watch for is what we call care fragmentation. So if you have a principal care provider who's doing chronic care management, and then you have, multiple different providers who are doing principal care management, Medicare would kind of question as to why the patient needs all of these additional doctors billing for that. But you can have more than one principal care management service for that patient by different practitioners of different specialties for different problems. Mary, anything else?
Not at this time, thank you.
Thank you. And so you'll notice on here that rural health clinics and federally qualified health clinics can also bill for this service. Now, there's a different procedure code that they would use, and that's at a couple of slides down. We'll talk about that code. But the important thing I want to let you know about here is that this is billed as an encounter. So even though it's generally a non-face-to-face service, rural health clinics and federally qualified health centers can bill for this just like they would bill for an evaluation and management service. Their payment for this under the procedure code is under the all-inclusive rate or under the prospective payment system for FQHCs. So you want to be aware of that because that is very different than any of the previous instructions for RHCs and FQHCs. Generally, only face-to-face services could have been billed to us, but this non-face-to-face service can now be submitted to us. And then that last one, the hospital outpatient department, this is where the clinical staff of that hospital can bill for the chronic care management services. Now, they would not be billing for the principal care management, but they can bill chronic care management or complex chronic care management. They would be working with a specific professional who is providing this service for the patient. Excuse me. And their documentation would be separate from the documentation of a physician who may or may not be able to bill for this, depending on the amount of time that they would have. So let's talk briefly about the comprehensive care plan. Well, the care plan is really what you're looking at to determine what the patient needs. You'll notice your slide here shows that it is patient-centered. And what we mean by that is that it is specific to Susie. Now, Susie and Bill both may have the same problems, the same chronic conditions, but Susie and Bill are not the same people. And so Susie, as part of her care plan, you are providing instructions to her on things that she can do to help improve her health. And you're providing instructions to Bill also, but Bill doesn't really kind of want to do some of that stuff. So, your care plan may be a little different. In addition to that, additional problems that Susie or Bill may have may be different. And so then your care plan needs to reflect that. And your care plan then directs what you're going to be doing during your care management services. Your care plan has to be electronic, so that number one, anyone who is taking care of this patient, your clinical staff, your practitioners, they have access to that care plan to be able to update it, to know what they should be monitoring, implementing, etc. You want to be able to share that care plan with additional practitioners who are involved in the patient care. So, you're the primary care physician, you're doing chronic care management for the patient, but they're also involved with a cardiologist. So, you need to be able to share that care plan with the cardiologist so that they're aware of what your plan is for the patient and the actions that you're taking. In addition to that, you want the cardiologist to be sharing what they're doing and their care plan with the patient so that you can update your care plan as you continue providing these services. The patient must have 24/7 access to clinical staff for treatment, for contact, for education, and the staff must have access to that care plan. Now, there's a lot of different ways that this 24/7 access can happen, and the person providing that 24/7 access, such as after-hour care, etc., they have to be clinical staff, and they have to have access to that care plan so they can update that with whatever information the patient has provided to them. Now, you can have, of course, a clinical staff person on call. You can use an answering service, but you want to be a little careful with an answering service. Number one, is that person who's answering the call, are they clinical staff? If they're not, then of course their time would not count toward your care management service. If they're not clinical staff, can they identify that this patient calling in today is part of your chronic care management program so that then they can get them to a clinical staff person? A lot of times when you call a physician's office after hours, the first message that will be on there is, if this is an emergency, you need to call to hang up and dial 911. For your chronic care management patients, you need to provide them a way to get to clinical staff. One of the goals for chronic care management is to reduce the need for emergency department visits or for hospitalizations. So, as part of that, the clinical staff may be able to provide treatment or education or information that would make it that the patient doesn't have to go to the emergency department. And then, of course, that conversation and the activities would be documented along with the time. The other thing I want to let you know about too is that if you are using an outside care management organization in order to provide this after-hour care or all of the care management services, the person who is providing that must be located within the United States. Um, some companies we have heard about, they have staff in other countries, especially to cover the after-hour care. but you can't bill for any of that time because Medicare does not pay for services provided outside the United States. So what are some of the contents of the plan and how are you going to use that during your care management service? Well, some of them are listed for you here on the slide. So you've got patient problems. Well, when you develop the care plan, you identified not only the chronic conditions that we're talking about, but any other problems that the patient may have. So during your care management, that's what you will be assessing. You'll be asking questions about, do they still have this problem? Do they not have this problem? Are there new problems? On the prognosis, if the prognosis for the patient is changed based on changes to the patient's condition, then you'll identify that. You'll want to look at the goals that you set, both for patient treatment, what you would be doing, what the practitioner would be doing, or clinical staff, and the goals for the patient. If you provided the patient a goal to walk, 3 times a week, are they meeting that goal? Do you need to adjust that goal as part of your care management service? Now, with the cognitive assessment, at the beginning, when you develop the care plan, you have made a determination as to whether or not that patient needed cognitive testing. And then if so, what the results of that testing was. As you're doing the care management, you'll check into that function again. Has that changed for the patient? Is there evidence of that change within the conversations that you're having with the patient? If not, then you'll just document that you don't see any changes that need to be made. The next thing then is functional limitations. When you develop the care plan, you identified that the patient could, walk for 20 steps before they ran out of breath, or whatever the situation might be, their range of motion, the activities that they could do. So when you're doing your monthly service, you'll ask about that. In the care plan, you said you wanted the patient to, take 100 more steps a day. Are they doing that? Is that helping to improve the symptoms that they received or that they were experiencing before you started this? So you'll just look there for any change in that patient's functional limitation. Symptom management is the same thing. You'll look at any symptoms that the patient reported earlier. That's part of your care plan. Are they still having those symptoms? Are they better? Are they worse? Are there any new symptoms that you need to include within your care plan? Planned interventions. This has to do with the patient's preventive services and also any labs, testing, visits with other practitioners. You'll just identify, okay, now it's time to have your annual wellness visit. Let's go ahead and schedule that for you. Or we want you to have an A1C test, and we want you to have that this month because it's been 3 months since you've had that. That's part of those planned interventions. And then under the medication management, this is going to be, are they taking the medications as they have been ordered? Do they need assistance with getting their medications right? Has anyone added a new medication or taking away a medication? And then as part of that, you'll look at those medications, make sure they're still working for the patient, make sure that there are no interactions that you need to be aware of, or no additional side effects that may have cropped up. So that's your medication management. So then we look at the environment. As part of the care plan itself, we ask questions for the patient about their living conditions. Do they have a safe place? Do they have housing? Does it have adequate heat? Does it have air conditioning? All of those types of questions. Do they feel safe in their home? So that's part of what you'll do during your care management. You'll ask about whether anything has changed and then document that within your record. For the care assessment or caregiver assessment, it again is just a continuation of what you did when you developed the care plan. Does the patient need one? If they still don't need one, then you'll just document that. If they do need one, do they have one? If they have one, is that person capable of providing them the support that they need? And then social services also goes along with interactions with other providers. Ask the question, have you been to the cardiologist since the last time that we talked? Have you been to a new practitioner since the last time we talked? You want to document that, and then you want to reach out to that practitioner so that you can get the notes from their encounter with the patient so that you can then incorporate that into into the care plan and then into the documentation for today's service. And then you'll look and determine whether or not there are changes to the care plan that you need to make. And if so, then you'll update that and then provide a copy to the patient, to any other practitioners that are involved. You'll also look at how you set the periodic review when you develop the care plan. Medicare requires that care plan to be reviewed at least yearly. Now, depending on your patient's circumstances, you may have decided you want to review every 6 months. Okay. So, in your care management service today, what's your decision on that? Is it still a periodic review 6 months from now? Has the patient condition changed enough that you really need to review the entire care plan today and as part of the service that you're providing to the patient? And then, of course, if you are making changes, as this slide shows, you do need to give a copy of that to the patient. You can hand them a written copy. You can do it virtually or electronically through your patient portal, through emailing it to them. It's really kind of a discussion between what you have available and and how your patient wants to receive it. You want to share that care plan when you have updated that with other providers. And then you can also be sharing that care plan with others who are involved in that patient's care if you feel like they need the care plan or portions of the care plan in order to continue providing great service to that patient. So what is the care management itself? Okay, well, it's again a monthly service. It is generally going to be non-face-to-face services, although you can include face-to-face time or face-to-face service as part of your care plan. Maybe the patient is more comfortable in coming in and having a conversation with that clinical staff as opposed to having it on the phone. Or maybe you want the patient to come in because you want to actually do the check of their blood pressure because you want to verify the information the patient's been providing you is accurate. So when we're talking about chronic care management, it is a full month worth of the service. So the best practice is to hold off on billing that until you get to the end of the month. That way you can capture all of the time that you have spent. In addition to that, you can capture whether or not you have chronic care management or you have complex chronic care management. The complex chronic care management includes not only additional time, but also that your billing practitioner has had to make a medical decision of either moderate or high complexity for that patient. One of the biggest reasons for denials that we receive or that we see on chronic care management is the fact that providers are billing the CCM and then also billing the chronic care management during the same month. And of course, Medicare is not going to pay for both of those. You have to have the required time. When we get a few more slides in, we'll show you the procedure codes and the time. You have to meet the time in its entirety. So for an example, one of the procedure codes is a 30-minute code. So you have to have documented at least 30 minutes in order to meet that procedure code. Medicare does not accept a midpoint time for any of these services that we're talking about. You want to identify what it is that you've provided to that patient. So your documentation could show that I called the patient on January 20th and we had a conversation about their medications, and the patient identified that the symptom that they were having last week, they're not having this week. So it's just a brief overview of the activities that you're providing for that patient. And then, of course, like I said, the time that you're doing for that. For the care plan, you're going to be following that care plan to identify what you need to do during this monthly service. Obviously, if the patient does not have blood pressure problems, then you would not be asking them to supply you with blood pressure readings. If the patient has blood pressure problems, has hypertension, and you're asking the patient to keep track of that, then that's information that would be documented within the care plan within that month to identify you need that. And then for the activities, you would show that you have received that. And then based on that, whatever actions you have taken. In addition to that, you need to identify the person providing this service. Again, as we talked about, generally this is going to be non-face-to-face by your clinical staff. So you'll just indicate in your documentation, RN Mary is the one who had a conversation with the patient, or LPN Susie had a conversation with the patient. The physician does not have to sign off on the documentation for this monthly care plan. Again, it is general supervision that they are providing to that clinical staff, but the person providing that service needs to be identified, and then they would be the ones who are providing the signatures for that. Now, during the monthly service, again, it's generally clinical staff, but your physician or practitioner may also provide services. You want to keep track of that also, because that can make a difference, number one, in the amount of time that you're going to submit, but also the procedure code that you can submit to Medicare. And then again, just as a reminder, that clinical staff that's providing the services does have to be within the United States. So what are the procedure codes that we have here? Well, you can see the first one is a practitioner code. And each of the different services, CCM, complex CCM, or PCM, have two different sets of procedure codes that can be submitted. You can see there we have a practitioner code. In order to use the practitioner code, the physician or practitioner has to supply all of that time. So all of that 30 minutes. When you're billing to Medicare, you choose only one set of procedure codes. So you only bill the practitioner time, in which your clinical staff time would not count toward that. That is physician or practitioner only. And then you can see there that there are two procedure codes. The first 30 minutes under the 99424. The second procedure code is each additional 30 minutes, and it is a full 30 minutes that has been provided to that patient. And then you can bill, if you have that amount of time, then you can bill both of those codes. For your clinical staff procedure code, you can see it's both 30 minutes or 30 additional minutes, same thing. However, the difference on this code is that your practitioner time can count towards your clinical staff time. So let's say, for an example, that your practitioner has provided 10 minutes of service for that patient for that particular month. Well, 10 minutes does not qualify under the 99424 procedure code, so therefore they can't bill under that. However, you can take that 10 minutes and add it to the clinical staff time, either to meet the first 30 minutes or to meet that each additional 30 minutes. So just to kind of say it again, clinical staff time does not apply to practitioner time, but practitioner time does apply to clinical staff time. The next one that we have there is then the chronic care management. And you can see the 2 procedure codes for the practitioner and then the 2 procedure codes for the clinical staff time. And then this next one is complex chronic care management. Now, you'll notice that the practitioner procedure codes and time did not change. It is still 30 minutes and each additional 30 minutes. The clinical staff time, though, did change. Now we're at the first 60 minutes for that patient during that month, and then, of course, each additional 30 minutes. In addition to that, in order to bill for the complex chronic care management service, documentation has to show that your practitioner, your billing practitioner, has provided medical decision-making of at least complex or moderate complexity. That doesn't have to be a face-to-face service. It can be evaluating that care plan and then making a medical decision based on the information that's in there. Now, that also could mean that you're changing the care plan, you're updating that with additional information. It doesn't always have to mean that, though. Your clinical staff could be providing information to that practitioner with something that they're concerned about based on what the patient has told them. Your physician or practitioner evaluates that information and makes a medical decision that I want to keep everything the same. That's still, they've made that medical decision. So you want to have that documented along with the time that they spent in order to do that. And then that time can count towards your clinical staff time. The hospital outpatient departments can submit both the chronic care management, the CCM, and the complex CCM. Hospital outpatient departments cannot submit the principal care management. So now let's look at a procedure code for the RHCs and FQHCs. You'll notice on here that there's only one procedure code. It's the G0511. This is for any amount of time that your physicians and practitioners and your clinical staff are spending on that patient. The information from the CMS MLN booklet does not assign a particular time to this. So that means a couple of things. Number one, you don't necessarily have to have that first 30 minutes. And if you have an additional 30 minutes, you still just bill that one procedure code with 1 unit of service. The reimbursement under the G0511 procedure code is kind of an average of all of the other procedure codes that can be submitted. And so again, that's paid under the all-inclusive rate, or it is paid under the prospective payment system rate. The AIR is for the rural health clinics, and the PPS is for the federally qualified health centers. One of the questions that we've had on this is how does the patient out-of-pocket expense work under the RHC or FQHC? And it works the same way as an evaluation and management service or any other face-to-face encounter that you have. Your AIR rate is whatever that rate is, and then the patient would be responsible for the 20% coinsurance of that. Mary, I see that you have your hand up.
Yes, I do. Thanks, Ellen. There's a couple of questions that have come in, and they're great questions. So I think it's perfect to share them with everyone. The question and then the answer, of course. The first question is from Jeff. He says he knows that MAs or medical assistants can apply or bill for their services directly. He wonders if any of the time they spend with a patient and collecting data would count towards some of their higher level providers' billing time. He's talking about NPs and PAs and physicians, of course, who do have Medicare billing privileges and who review the MA data before they speak with their patients for their CCM services. So in short, do the MAs have any role or place in chronic care management services?
Sure, they do. Now, a medical assistant cannot enroll with Medicare, so they cannot be the billing practitioner, nor can they be a supervising person over additional clinical staff. They would be considered, or they could be considered, let me put it that way, excuse me, as clinical staff. The AAPC has a really good definition of what is considered clinical staff. Now, the CPT books, and it kind of depends on which book you have, but the CPT book also includes the same information. Generally speaking, your clinical staff are going to be licensed or certified by the state in order to do whatever their certification is. So your registered nurse, for an example, is going to be licensed by the state. Some states, however, don't license medical assistants. So as part of that, the AAPC and CPT definition, it also goes on to state that your facility can consider them clinical staff. And so if that's the case, then your facility, whether it's your clinic office, hospital outpatient department, the RHC, FQHC, et cetera, what you'll need to do is you'll need to have documentation as to, number one, that you do consider them clinical staff, and then number two, what are they allowed to do under your umbrella? Can they do injections? Can they do, chronic care management? Can they, whatever it is that they can do? And so then should Medicare request that, you have a document to show that you consider your medical assistant a clinical staff person, and here's why, and here's what they can do. Okay, Mary, do you have another question?
I do. This one is from Casey. With some services that are non-face-to-face, this can include audio only and video and audio. Does messaging through a patient portal back and forth in regards to question about care or medications or something within the care plan count towards time?
This can count toward time when you're messaging back and forth through the portal. This really isn't one of your best practices, though. If your patient is more comfortable with that rather than having a conversation or video chatting or something, and a video chat obviously is not required for this, then you can use it. Really, this is an interaction as part of the monthly care plan service is going to be an interaction with your patient. So if that interaction is through your portal, um, you are showing that it is information going back and forth as opposed to, just posting the care plan itself, then yes, you could count this time. In addition to that, if you have the patient come in or the patient wants to come in to talk to the nurse, that time also would count towards your monthly service. Any additional questions right now, Mary?
That's it for now, Ellen. Thank you.
Okay. The other thing that I want to kind of remind you about before we go any further, is that these monthly chronic care management services do not preclude you from billing for other services that you may be providing to the patient. So for an example, you're having the patient come in January to do an annual wellness visit. Well, that's billable separately. You just want to make sure your documentation supports what goes into your annual wellness visit and that you're not using any of that information or that time in order to bill for the CCM, the procedure codes for chronic care management. In addition to that, you have the patient come in for an evaluation and management. Same thing. You just keep your documentation separate. Now, there are other services that you could provide either inside chronic care management or outside chronic care management. And this has to do with remote patient monitoring or remote therapeutic monitoring. And so what we mean by that is if you're going to bill separately for those two types of service, you would not count any time that was spent on that as part of your chronic care management. If you're not billing those, but you're using that information as part of your care plan, as part of implementing that care plan, revising that care plan, etc., having a conversation with that patient, then you can count that time toward your chronic care management service. Okay, so we just want to remind you here, for the time it has to meet or exceed whatever the procedure code shows, and then your practitioner time can count toward clinical, but your clinical cannot count toward your practitioner. We've also had a question, and we've received this several times, concerning residents. And can a resident perform this service? How does this work? Well, a resident service is reimbursed by Medicare under two different ways. One is called the teaching physician guidelines. And under those guidelines, that teaching physician has to be present with the resident during the key and critical portions of the service. Well, for chronic care management services, and that's the umbrella term, that means that that's the time that is being spent during that month. So the resident's having a conversation with the patient. That means that teaching physician has to be right there, present, and part of that conversation. Since CCM services are generally non-face-to-face, we really don't anticipate that that's going to happen. The other way, though, that residents can be reimbursed, or services that a resident provides can be reimbursed, is under what is called the primary care exception. And this is a certain list of procedure codes that would need to follow the primary care exception rules. Chronic care management, complex chronic care management, principal care management is not under the primary care exception. So therefore, Medicare would not reimburse for that. However, your residents count as clinical staff time. They don't count as practitioner time, but they can count toward the time under the clinical staff procedure code. So what's just some other information to let you know about them? Again, just a reminder, this is a monthly service. So you really want to hold your billing until the end of the month. Now, you can use the end of the month as your date of service. If you talk to the patient on the 20th, you can use the 20th as your date of service. That's just kind of up to you. But you want to be able to capture all of the time. Not to mention, if the patient requires that moderate or high complexity medical decision making, you want to capture that. because the complex chronic care management procedure codes obviously reimburse higher than the chronic care management services. You just want to make sure that you're gathering your time, and remember, time is not only, I spoke to the patient for 5 minutes, but I had to take 5 minutes to update that care plan and update the patient's medical record, or I spoke with the patient for 5 minutes, but then I needed to contact the emergency room because the patient went there since the last time we talked, and I need to get those records. And then I spent another 10 minutes reviewing those records. All of that time is part of your chronic care management service. You are providing a service, you are working for that patient, you are working to improve that patient's health and provide absolutely wonderful care to that patient. Document the time and then bill for the time. And then there are some things that you can't bill during the same month. One of the things that you cannot bill in the same month that you're doing any of these chronic care management service is a prolonged care service. So this means even if you do an evaluation and management and you say, oh, I have this additional time and therefore I could bill this additional procedure code. If you're also billing for CCM during that same month, you cannot submit any of the prolonged care codes. That includes the G2212, the G0316, 17, and 18. So you just can't bill prolonged care codes. That time, if you're dealing with the patient's chronic conditions and the problems, and under that chronic care management umbrella, put that time into your CCM. In addition to that, you can't bill for home health or hospice supervision or care plan oversight, the services Medicare considers to be duplicate. If your patient has end-stage renal disease, then those assessment procedure codes, if you're billing for those, then you would not bill for chronic care management services. And then, of course, you can't bill both a practitioner code and a clinical staff procedure code in the same month. You also want to evaluate the National Correct Coding Initiative for any additional edits that may apply when you're billing on the same data service. And then, we talked about you can't do both CCM by a practitioner and a clinical staff at the same time. Billing by a hospital outpatient department is an exception to that. If the practitioner meets the full time for their procedure code, they can submit that. And then the hospital outpatient department can submit for the services that they're providing. So that's the information that I have to provide to you. Mary, I see you have your hand up. We'll go to questions in just a second. What we have up on your screen right now is a QR code for a survey. CMS requires Medicare contractors to survey attendees to our educational offerings. You can use your phone in order to take this survey. Just kind of take a picture of it and then it will take you to that website. You also have the same QR code in your handout. Again, you can use that with your phone to take the survey, or in your handout, it is also a link. So you can, hyperlink that, go into the survey, and take the survey that way. And then the same link is in the modules in the Learning Center. So if you're taking the survey either through what's on your screen, what's in your handout, you'll need to open the survey module, but then of course you don't want to take the survey twice. So Mary, what questions do we have?
We have one question, and this one is also from Jeff, and it's a good question. What place of service codes would be acceptable for CCM? They are planning on using place of service 11, which is office, since they have an office, but he wonders if there is a more appropriate place of service code.
No, generally speaking, Medicare doesn't have restrictions on this. Office is probably going to be the one most commonly used. And then, of course, you also have the place of service code 22 for if you're providing the service through a hospital outpatient department. And what we mean by that, because your patient's not going to be in the hospital outpatient department. Again, these services are generally non-face-to-face. But if your physician is a hospital-based physician, then place of service code 22 would be appropriate, 11 would be appropriate, etc. Any additional questions, Mary?
There are none at this time, thanks.
Okay. Well, I am showing that we have 1 minute left. So just a couple of things. We ask you please to complete the survey. Again, you know, WPS GHA as a contractor has to report that information back to CMS. And then just myself and the rest of my colleagues as your presenters, we want to make sure that we provided you with the information that you need. If you have suggestions for us, please tell us that. If you feel like this presentation was absolutely fantastic, then please tell us that too. Just one more thing. We want to, as we talked about, we will receive information from our vendor later this afternoon. We'll go in, we'll update the Learning Center with the fact that you have attended, and then we'll be able to, you'll get an email from our Learning Center, and then those additional models or modules will open up. And Mary, I thought I saw one more question pop up, but I didn't see the whole question.
There is one more question, and this is from Catherine. Am I hearing that the physician's office could bill a clinical staff CCM code, which would be 99490, and also an HOPD, a clinical staff CCM 99490, if the hospital staff performs this?
No, what we're talking about here is the exception to the rule is that the hospital outpatient department is the clinical staff. Okay, so they're the ones they're providing their services under the supervision of another practitioner, but they're providing CCM. If the hospital outpatient department bills for CCM and the physician's office under the clinical codes bill for CCM, then it's paying two different providers for the same service. So no, Medicare would not pay for that. What you would have though is that your hospital outpatient department is doing the CCM, working under the supervision of a practitioner, or you have arrangements with hospital staff, hospital clinical staff to do your after hours coverage, in which case it would be billed by that practitioner, and that time would encompass and be billed by that practitioner under the incident 2 requirements. One of which in this situation, you'll have to have some type of an employment relationship between that practitioner and the staff that are going to do that after hour care that are at the hospital, located at the hospital at the time of service. Okay, any additional questions, Mary?
There are none.
Okay, I want to thank everyone very much for attending today, and thank you for your patience with our difficulty the other day. This concludes all the information. Watch for the email, and you guys have a wonderful, great day.